Thanks, Andy. To come and talk about a couple of things this evening, and then 3 days ago, Andy sent me an email and said, actually, could you talk about this instead? So bear with me as I just use a few notes as I'm talking this evening. And what Andy asked me to cover was, where do we think cancer research is going to go over the next 10, 15 years in prevention, in diagnosis, in treatment, in palliative care, and in everything else? So I've got 10 minutes to cover that entire spectrum. So I'm not going to say anything about Cancer Research UK other than we have been involved over the years in developing a huge number of drugs that are used around the world in radiotherapy techniques and screening programs and so on. And of course, we've come a long way in cancer since the days when people talked about it in very hushed voices. Survival rates have improved hugely over the last 10, 20 years. And we at Cancer Research UK, what we want to do is to improve those survival rates much, much further, such that we can cure all of the cancers, not just some of them. Just a couple of stats on that, just because you've heard some other stats this evening, so I'll give you some of mine. Currently around the world, around 13 million people are diagnosed with cancer every year, and around 8 million people die of it. By 2030, we're going to have 30 million cases a year, and about 13 or 14 million people dying from it. It's already the biggest killer in countries like the UK and the US. It's going to become very much the biggest killer worldwide. So now, I'm sure all of us know how we use science to help illuminate biological pathways that are often aberrant in cancer. And when we understand those aberrations, we can try and modulate them with drugs, which can help us to halt or reverse the cancer. So we use our biological insights to essentially to identify new drug targets, and that helps drive therapeutic innovation. But sadly, as many of you will know, with some notable exceptions, and there are some notable exceptions, that approach hasn't really delivered us massive health gains in cancer. Most of the new drugs deliver a few or several months of extra life for the patient, which of course is incredibly valuable to them and their family, but it doesn't actually give us the sort of step changes we're looking for. And there are many, many reasons for that, some of which we understand, some of which we absolutely don't understand yet. So we need to continue those approaches, because what they do help us to do is they give us a bigger treatment arsenal. And we need to continue growing that arsenal, and it wasn't so long ago that we had almost nothing in the cupboard. So I'm going to touch on 4 areas that I think are going to be really important over the next 10 or 15 years that I hope to see huge developments in. So I'm going to start with something what I call targeted prevention. So the premise here is, if we can figure out who's at greatest risk of getting cancer, then we can offer them lifestyle advice to reduce that risk, or we can monitor them more closely or more frequently, hopefully pick up very early signs or pre-invasive lesions that we can do something about, or indeed we can medicate them with vaccines or chemopreventive drugs. But the toughest challenge in this is to figure out the people in whom we should intervene. So we need to develop the algorithms that will help us to define for an individual whether they're at high risk or not. And undoubtedly that's going to be some combination of genetic susceptibility, with information on their lifestyle, with exposures to environmental factors, a whole range of things, some of which you've already heard about. But we also need to understand who's at greatest risk from any intervention we might use, because almost no intervention is without some risk attached to it. So what we need to do is combine some really quite complex and quite different data sets and apply critical analysis to them to give us some algorithms that can help us think about how we apply that in a preventive sense. And the intervention itself might actually be quite low tech. It's the identification of the individual that's the challenge. So let me give you an example. So over the last couple of years, there's been a huge number of publications that show that aspirin, a very commonly used drug, appears to have a very strong preventative effect in colorectal cancer and indeed a whole number of other GI-related cancers. It also appears to have a strong secondary preventive effect, by which we mean it stops cancer spreading around the body. And so we're already starting to think about how we might use aspirin in different settings. But the issue is, although we can see the population benefit of something like aspirin, we also know that in a significant number of people, it has strong adverse effects. In the case of aspirin, GI bleeds. So we're not ready to recommend that everyone from the age of 50 starts taking aspirin on a daily basis. We need to be much cleverer than that. We need to figure out who we should be recommending aspirin to, how long they should take it, what dose they should take it, given their individual risk. If we can grasp this challenge, the potential benefit is absolutely enormous. Colorectal cancer alone is the second biggest killer from cancer. And as I say, something like aspirin helps in a whole number of other diseases as well. So the second area I'm going to touch on is that of earlier detection of disease. Now, we know that for the vast majority of cancers, if we can detect them early, usually it gives us a much better chance of treating it successfully and often curing the disease. If we, on the other hand, treat more advanced disease, which is what happens in the vast majority of cases, then we know that both the cost of treating and the probability of failure are an order of magnitude higher. But of course, catching cancers early is difficult, otherwise we'd catch them early. But the very fact that we can catch some early should give us some hope that actually we can do better if we can just figure out exactly what to do. So some of our focus is on how we get people to recognize symptoms. Some of it is on overcoming the sort of psychological barriers that stop people going to see their GP when they have some symptoms. To some extent, it's about improving diagnostic technologies. To some extent, it's about arming GPs with tools that they can use in their surgeries, at the very least, to be able to triage patients. But we also need other approaches. Now, detection technologies across a whole range of industries have become ever more advanced, ever more sophisticated, and ever more sensitive, meaning that we have the ability to use those technologies to detect very tiny markers in very tiny concentrations in very tiny samples. And what we need to do in cancer, and indeed in other diseases, is to identify what those markers are, where they are they in the blood, are they in the urine, are they in breath, how they change over time, and we need to do all of this before a cancer presents symptomatically. We can do this. We absolutely can do this. It requires a combination of very large sample collections from healthy people with long-term follow-up data on what diseases they develop. We then need to test those samples with a whole range of technologies, sometimes combinations of technologies, to figure out which ones give us the best sensitivity and best specificity for detecting a disease. And what gives me optimism that this is possible is not just that we're doing it already, but if we can detect the presence of a particulate in a stratum of a rock on Mars using very old technology, why can't we use some of the technologies that we're developing in other industries to look for the presence of markers, proteins, antibodies, cells, whatever they may be, in the blood or in the urine? So it means that we need our scientists thinking, not just as they have done traditionally, about how they might develop a new drug from the biological insights they're developing, but how they might develop a new diagnostic, a new detector, a new marker of early disease. And actually, this isn't just about technology development. It's also about the whole cultural way we do science and R&D. We need to pull some of these discoveries out of the science labs in the way that currently we pull those discoveries out to develop new drugs. So let me move on to the third area, which is about more precise diagnosis. And there's a theme here running through the speakers, as you'll have picked up. Some of you may have seen the results of a review that was carried out that we published about 2 weeks ago on the breast screening program here in the UK, but this applies right across the world. In summary, the results of that review showed that breast screening does save lives, but it does so at the risk of overdiagnosis, by which we mean we detect some cancers. They're real cancers, but they're cancers which otherwise wouldn't have gone on to cause a woman a problem during her lifetime. In other words, she would have died of something else before the cancer became a problem for her. The problem is, at the moment, we can't tell which is an aggressive cancer that might cause a problem and which isn't. And so what doctors end up doing is they end up treating all of them. And so an awful lot of women get treated unnecessarily because of that, because we can't distinguish. So we need to figure out how to do this, not just for breast cancer, but for prostate cancer, indeed, a whole bunch of other diseases. The corollary of earlier diagnosis, which I've already touched on, is that we don't necessarily want to create a whole cohort of patients who would otherwise be untroubled by a disease during their lifetime. And again, this isn't just a problem in cancer, it's a problem in a whole bunch of diseases. So how are we going to do this? Well, obviously, genomic analysis is one opportunity that we have in front of us. And there's a huge amount of effort going on in genomic analysis for distinguishing between different types of tumours right across the world. Indeed, here in Cambridge, there's a huge amount of work going on. But we also want to explore other less invasive technologies, detecting in blood circulating tumour cells or circulating DNA, antibodies or other proteins, or indeed something else entirely that you guys might be aware of that I'm not. So the fourth area, the final area I want to touch on is what I'm going to call truly individualized medicine. Increasingly in cancer, you'll hear the term stratified medicine, personalized medicine. What we tend to mean by this is that we look for a marker, usually a genetic marker or a protein marker, which helps us to stratify patients into different groups, which helps us to say, okay, this group should get a particular drug, this group shouldn't. The problem, as I've already touched on, is that many patients in cancer become resistant to drugs. They relapse, their cancer recurs. And it's quite likely, as we're increasingly learning, that the sheer volume of mutations in any particular tumour, or indeed in different sections of the same tumour, make this approach only partly successful. And there are other mutations that emerge, or the cancer evolves, that means that treatment no longer is as effective as we hoped it would be. So the likelihood is that we're going to need to try very different combinations of drugs in very different schedules according to the evolution of a cancer in each individual patient. You might think of this, you might describe this as every patient becoming their own individualized clinical trial. This probably isn't going to happen in the next 10 or 15 years. But if I had to project forward, I don't think we're going to be treating patients in 30 years the way we're treating them today. We need to use very close monitoring, almost continual diagnosis and re-diagnosis. And those diagnostic technologies, in my view, are going to become as important, if not more important, than the treatments themselves. Knowing which treatments to give, just as importantly, which treatments not to give at any particular point in time is going to be transformative for the sorts of outcomes we can deliver for patients. Because actually, increasingly, the treatment cupboard itself is getting fuller and fuller. We just don't know how to use those treatments well enough. So we need the right technologies at the right price. We need to figure out how to use them, and then hopefully we can figure out how to deliver the best for our patients. So what I've tried to illustrate through these 4 examples is nothing about developing new treatments, because that will go on anyway, and it will continue, and we will have a fuller and fuller arsenal. Our success against cancer has been great over the last 3 or 4 decades. If we can make these sorts of developments that I've touched on over the next 10 or 15 years, which, by the way, I think are going to be pivotal, I think, as I say, we can transform the landscape looking forward. But again, it requires not just new technologies, it requires different ways of people working together across different diseases, across different industries, biologists working with engineers and physicists and computer scientists in a way they haven't done before. And so the final point I'll make is just that that's partly what we are trying to encourage as Cancer Research UK in various centres around the country, and through developments like the Francis Crick Institute in London, is really to get a sort of cultural change in terms of how we get people from very, very different disciplines working together to tackle some really tough problems. Because if we can do this thing, then if we can do these things, we may not eliminate cancer, but we certainly can look forward to a day when many, many, many more cancers are cured. Thanks.